So let's now review the important points that we've learned about the anatomy of the dorsal apparatus. We call it the dorsal apparatus because a portion of it flexes the metacarpal phalangeal joint, and therefore it seems somewhat inappropriate to call it the extensor apparatus or the extensor aponeurosis or to use the word extensor. It is an amalgamation of multiple layers of tissues running in different directions. These fibers are I would call them ornate. They're so beautifully constructed. It's an interplay of tension between fiber groups that creates finger extension, and then it's a change of angle that allows finger flexion. The dorsal apparatus on the cadaver will provide insight into how variable this anatomy can be. Of particular, I've noted that the central slip often is very different on different cadaveric specimens. This one, you see that there seem to be multiple broad tendons, whereas one on this side and one on this side is actually the conjoined lateral band. In other specimens, there may be one central portion that appears very significant, and it may be somewhat difficult to appreciate the contribution of the conjoined lateral band. In any case, the anatomy, even though variable, because it works together, it ends up being functionally the same. The fibers in the dorsal apparatus are relatively parallel to one another when the finger is in extension, but finger flexion allows one group of those fibers to move into a greater angle, and that's what allows this non-elastic dorsal apparatus to move and provide the ability for the finger to flex without undue tension. Because the lateral aspects of the dorsal apparatus move laterally and volarly during normal finger flexion, the dorsal apparatus will accommodate the contour that's created during finger flexion. The sagittal band fibers are very important fibers that centralize the extensor digitorum communis at the metacarpal phalangeal joint. These fibers encircle the entire metacarpal phalangeal joint and are an important part of the stabilizing structure of the metacarpal phalangeal joint. These fibers are attached to and move with the extensor digitorum communis both distally and proximally, but because of their attachment to the volar plate, they pivot on the volar plate and do not move distally and proximally here. Because of this attachment, the sagittal band fibers limit the excursion of the extensor digitorum communis both proximally and distally. Even though the extensor digitorum communis is an extrinsic muscle moving very freely with significant amount of excursion, one can no longer apply that concept of free, unrestrained excursion or significant excursion once the EDC has inserted via the sagittal bands. This insertion is the primary extension force for the metacarpal phalangeal joint, and it's extremely unique because it is not a tendon crossing a joint and inserting into bone. It is rather the pull on the EDC via the sagittal band fibers that lifts the proximal aspect of the proximal phalanx into extension. A very unique insertion. The sagittal band fibers, as we said, are part of the metacarpal phalangeal joint capsule. Therefore, if you look at the entire dorsal apparatus with its attached tendons and muscles, The sagittal band fibers will be the most proximal portion where you see the thickened area around the MP joint capsule. The sagittal band fibers are adjacent to the transverse fibers, which are the most proximal fibers, but these fibers overlap one another, and your ability to see them as separate structures is dependent upon positioning the MP joint in flexion to be able to see them. The extensor digitorum communis is called the extensor digitorum communis until it is distal to the sagittal band. At that point in time, it becomes the central slip of the dorsal apparatus. Although the extensor digitorum communis has a significant influence on the dorsal apparatus, it does not continue straight out the finger to extend the interphalangeal joints primarily. Its primary contribution is tensioning of the dorsal apparatus proximally so that the smaller muscles can be more effective in extending the interphalangeal joints. The continuation of the extensor digitorum communis within the dorsal apparatus often does demonstrate a primary central slip or central portion where tension is carried. But the challenge is the fact that many individuals use the term central slip for the specific insertion within the dorsal apparatus. We have clarified that the central slip is the central portion providing tension, and the central slip insertion is specifically called an insertion. Here on the cadaver we see again that the central slip would continue straight until it is distal to the proximal interphalangeal joint, where it then inserts into the dorsal aspect of the middle phalanx. The central slip is the central portion. The central slip insertion is the insertion point. Here, illustrated is the actual insertion. As we discussed, this is not the singular point at which force is directed for PIP joint extension. It certainly contributes to PIP joint extension, but it shares its ability to extend the PIP joint with the contributions from the entire dorsal apparatus tension, as well as more specifically the lateral bands. Perhaps it's useful to think of all of the fibers within the dorsal apparatus as being a different musical instrument. And at any time, no one can play an instrument alone, but it must be in concert in order to make the beautiful music that we would translate as motion. So the central slip insertion, although a very important part of the dorsal apparatus, if the dorsal apparatus remains intact and the central slip insertion is disconnected or incised, normal finger motion is still possible, because the tension alone then is enough to extend the finger. It's only when there is a hole created in the dorsal apparatus so that there's a lack of continuity that the loss of the central slip insertion becomes significant, because then the entire dorsal apparatus moves volarly because the bone at the PIP joint will punch up through that hole. Now we'll talk more about boutonniere injuries and understand those in greater detail in subsequent sessions. So just a reminder that we want to specifically call the central slip area differently from the central slip insertion. Unfortunately, as you read the literature, this terminology will not be used precisely. The central slip insertion is that one point that inserts into the dorsal base of the middle phalanx. The transverse fibers, as we've discussed, are the proximal most portion of the dorsal apparatus. They are separate from but overlapping the sagittal band fibers proximally. They run parallel to the sagittal band fibers because both the transverse fibers and sagittal band fibers are transverse across the proximal aspect of the dorsal apparatus and over the metacarpophalangeal joint. In subsequent discussions, we'll clarify how the role of the transverse fibers change specifically based on the position of the metacarpophalangeal joint. If you imagine a pull here with the metacarpophalangeal joint in extension, these fibers are not going to be very effective in beginning the flexion of the MP joint. So they are more effective the greater the flexion of the MP joint. But we will revisit that. The transverse fibers we see very clearly here, distal to the sagittal band area and running transversely across the proximal aspect of the dorsal apparatus. We can see here transverse fibers, and then we can see overlapping the beginning of some oblique fibers. The oblique fibers cover the majority of the proximal aspect of the dorsal apparatus. They do come together and insert as the central slip insertion. But you may recall that we said that these fibers alone do not extend the PIP joint. Here they look very powerful. But remember, they are part of the dorsal apparatus, not separate from. And these fibers, as well as the conjoined lateral bands not illustrated, when there's tension in the oblique fibers, the conjoined lateral bands and these fibers would increase the tension in the lateral bands. In other words, proximal pull on the oblique fibers pulls the entire dorsal apparatus proximally. That's one reason that we are unable to extend the PIP joint without also extending the DIP joint, because all of this needs to move together. So this power, although it appears to be directed toward PIP joint extension, it is actually shared power that is influencing the entire dorsal apparatus. So if you have the occasion to look at a cadaver or to be in the operating room, see if it's possible to identify the difference in the transverse and the oblique fibers. This can best be done by flexing and extending the fibers and watching the relationship of how they move in relationship to one another. As we said, the oblique fibers cover the majority of the proximal aspect of the dorsal apparatus. They're not separate. They don't move separately. They are a distinct part of, although they're not distinct from. The terminal tendon insertion receives all the power of the dorsal apparatus. One would think that this is a terrific amount of power because it's a gathering up of all the fibers within the dorsal apparatus. But let's go back to when we looked at the insertion at the sagittal band, proximal phalanx, central slip insertion. Those multiple insertions actually tether down or tie down the dorsal apparatus so that any pull of a muscle proximally is not going directly to the terminal tendon insertion. It's somewhat restricted by these other insertions. The lateral band has the most direct line of pull to the terminal tendon insertion, and as we discussed, the extensor digitorum communis, which becomes a central slip, has an indirect route to get any power to the terminal tendon insertion. Therefore, we don't really describe this as the insertion of the EDC. It is indeed the insertion of the dorsal apparatus. That means it combines the power of the extensor digitorum communis, the lumbrical muscles, and the interosseous muscles. The terminal tendon insertion has very little excursion, but it is a very, very important part of the biomechanics of the dorsal apparatus, because if the terminal tendon insertion is disconnected, that means that the dorsal apparatus will want to retract, and all the muscle power is now going to be directed toward this insertion, because that's the end of the line if this is disconnected. So the terminal tendon insertion is very important for the balance of motion within the finger. In my view, a mallet finger injury is indeed a major injury to the balance of motion of the finger. And because there's such little excursion, there's very little tolerance for change of length. And therefore, a mallet finger deformity can become a very chronic problem of creating imbalance. The lateral bands we discussed are not distinct separate tendon structures. They are the thickened edges of the dorsal apparatus that specifically carry power, but they also share the power. You cannot pull on the lateral bands proximally without moving the entire dorsal apparatus proximally, and simultaneously you're providing tension throughout the dorsal apparatus. The most direct line of pull is to the terminal tendon insertion, but because of the conjoined lateral bands, there are always contributions to the central slip insertion as well as to the tension of the entire dorsal apparatus. The lateral bands at the PIP joint are never fully central or dorsal, and in normal finger flexion, the lateral bands move both laterally and volarly at the PIP joint, but they do, during finger extension, then come both dorsally and medially, but they never come to a central location. Because they are not central at the PIP joint, they are not very strong PIP joint extensors when the PIP joint is flexed. The closer the PIP joint gets to full extension, the greater the contribution of the lateral bands, because they are moving dorsally, and the more dorsal they move, the more mechanically effective they are in extending the PIP joint. The lateral bands seen here are very thickened edges, and it should be noted how the lateral bands don't go straight in an oblique manner, but they do circumvent the PIP joint. Imagine that this is a small mountain and they have to drive around the mountain before they get to the terminal tendon insertion. This accommodates the ability of the PIP joint to flex and create a prominence, and the lateral bands go around that prominence. The conjoined lateral bands may not be readily apparent on a cadaver, but they are present in that there are always fiber groups that interconnect lateral bands to central slip and central slip to lateral band. This conjoined lateral bands are in addition to multiple other interconnections, providing absolute assurance that no part of the dorsal apparatus will move without the adjacent part coming along for the ride. I will say again that it is impossible for the human finger to extend the PIP joint without the DIP joint also extending. The primary reason for this is the interconnection of the dorsal apparatus, preventing very much excursion to being directed toward one joint without it also simultaneously being directed toward the other joint. The conjoined lateral bands may appear very clear on a cadaveric specimen, or they may be very wispy and very difficult to define. In this specimen, they appear to be very long and very dramatic. In other specimens, they may be relatively short and relatively insignificant. But regardless, there will always be an interconnection within the dorsal apparatus that demands that the tissue moves in concert. The transverse retinacular ligament may appear insignificant until pathology is present. The primary role is to prevent the dorsal movement of the lateral bands. This dorsal movement can only occur when the PIP joint is hyperextended. Therefore, the transverse retinacular ligament is most useful in preventing the dorsal movement of the lateral bands in the presence of significant PIP joint pathology. In a swan neck deformity, the transverse retinacular ligament has adaptively lengthened and is no longer effective at retaining the lateral bands. The triangular ligament provides an opposite function. It prevents the lateral bands from separating during finger flexion, and it does so to then assist the lateral bands to move more dorsally during finger extension. In a long-standing boutonniere, the triangular ligament will be adaptively lengthened and will no longer provide assistance in maintaining the lateral bands close to one another toward the midline. The oblique retinacular ligament is a group of fibers crossing two joints obliquely. It therefore is on the flexor surface of the PIP joint and on the extensor surface of the DIP joint. It does create a relationship between movement at these two joints, the extent of which is debated. It also provides some lateral stability since it appears on both sides of these joints.